All right. The other interval that we need to pay attention to will be the QT interval. The QT interval, and we have said earlier that the QT interval represents the time all the way from ventricular depolarization to the end of ventricular repolarization. And we have said earlier as well that this QT interval is actually inversely proportional. It's proportionate to the heart rate, so that as the heart rate increases, we expect that the QT interval will be shortened, and the opposite is true. So if the heart rate should decrease, we expect that the QT interval will increase. And because of some of these variations and how they may affect standardized reading, then we have the corrected QT interval, and that is a QT interval that has been corrected at the standard rate of 60 beats per minute, so that the reading can be uniform across. So we say for a QTC that is more than 440 milliseconds in a male, we say is prolonged. And if the QTC is more than 460 milliseconds in a female, we say it is prolonged. Some possible causes of prolonged QTC will be electrolyte imbalances, for example, hypokalemia and its cousins, brothers, the hypocalcemia, hypomagnesemia. We can also find prolonged QT or long QT and a long QT, congenital long QT syndrome. Sometimes too, we may find it in conditions like raised intracranial pressure, severe hypothermia, and all of that. So it is important. I know a number of us may not be very interested in looking at the QTC, but it is important for us to look at it because it gives us some vital information. The QTC is said to be abnormally short if it is less than 350 milliseconds. 350 milliseconds. And causes still include electrolyte imbalances, for example, hypercalcemia. And just like we have the congenital long QT syndrome, we also have congenital short QT syndrome. And so that is the other another cause of a short QT. So somebody may be interested in finding out how to measure. Are there any things to pay attention to when we are measuring the QTC? Remember, we have said that for the QTC, once we get the QT, there are several formulae and even online that we can quickly use to compute. But in reading the QT from the ECG itself, we need to make sure that we are not taking just one reading, but we are taking looking at several successive beats, so that we arrive at the maximum interval, and it's that maximum interval that we need to use. The QT is usually measured in lead 2 or V5 and V6, and it is important, as I have said, not to just focus on one particular beat, but several beats, so that we pick the maximum interval. When we are trying to read or measure the QT for U waves, that appear fused to the T wave, not very, very distinct from it, you have to count that or measure that as included in the whole interval. But for those U waves that appear clearly distinct from the preceding T wave, those ones should not be included in the measurement. All right. So that does it for QT interval, and then a few things of interest. The next major thing we have to pay attention to when we are reading our ECG will be the QRS complex. The QRS complex. And what are we looking for? We are looking out for the width or the duration of the complexes, the voltages, and then of course the morphology that may be pointers to some peculiar or spot diagnosis. right? We mentioned that the Q wave is the initial negative deflection of the QRS complex. And we said that we expect to find these small Q waves in the left lateral leads, the left lateral leads, right? So for any reason at all, if you look at V5, V6, and AVL, and we do not find the Q waves together with other findings, of course, it may give us an idea whether there's, for example, a left bundle branch block, So it is important to pay attention to that small negative deflection. That is the first deflection of the QRS complex, right? And it's also important to look at that because there may be pathological Q waves. And we said earlier that for pathological Q waves, they are deeper and wider than the normal expected Q waves. And of course, we know where we expect to find the Q waves in the left lateral leads. So finding Q waves in other places should raise some eyebrows for us to try to find out why they are there. All right. The normal width or duration of the QRS complex is between 70 to 100 milliseconds. Most texts will extend it to 110 milliseconds, but beyond that, it is abnormal. And particularly when we are interested in talking about QRS complexes which are wide in bundle branch blocks, whether right or left, we want to see such complexes that are more than 120 milliseconds. We have said earlier as well that whether the QRS is narrow or wide is also a pointer to the origin of the whole rhythm. So if it is narrow, that is within the 70 to 110 milliseconds, then we say it's likely supraventricular. But if it is wider, then it's either of a ventricular origin or a supraventricular origin with an aberrant conduction. So as we will find in the bundle branch blocks that we just mentioned, or in electrolyte imbalances like hyperkalemia. With respect to the voltage of the QRS complex, when the voltages are increased, it may usually be representative of, say, left ventricular hypertrophy. Of course, that will have so many ways of trying to identify, in terms of so many criteria that may be helpful in trying to establish that hypertrophy. We will not talk too much about it yet because we'll be discussing hypertrophy in much detail. But as we all know, some of the criteria most commonly include the Sokolov-Lyon, we have the Cornell, modified Cornell, and a whole lot of other criteria. But once we see that the voltages are increased, then we may be interested in looking out for the possibility of, say, a left ventricular hypertrophy. On the other hand, if the QRS complexes, the voltages are low, and this is defined as voltages less than 5 millimeters in all of the limb leads, or less than 10 millimeters in all the precordial leads. If this is the case, then the possibility is usually, say, from a damping effect from say fluid or fat that has become interposed between the recording electrodes and the heart tissue, right? If it is not a damping effect from fluid or fat, the other thing that may explain it is loss of myocardial tissue. So maybe the person has had a prior MI or very, very last stage of say a dilated cardiomyopathy, where the muscle activity is very minimal. In such cases, the QRS complexes may be seen as low voltages. So with respect to, say, the damping effect, if we have a massive pericardial effusion, because of the presence of that fluid, the conduction of the electrical activity to the recording electrodes will be impaired, and so the voltages may be low. That may also be the case in in obesity, where fat will be the source of that damping effect, emphysema, pneumothorax, where air will be the culprit in terms of the creating that damping effect. The other thing we mentioned was loss of myocardial tissue. So, for example, the MI and then the last stages of DCM that we have talked about. So the other thing about the QRS is the axis of the QRS. And we said that the axis is just the sum of the depolarization vectors, overall vector of vectors in terms of the ventricular depolarization, and that has been said to be between -30 to +90, -30 to +90. So when we talk about a left axis deviation, then all we are saying is that the axis is deviated beyond -30. And when we talk about a right axis deviation, all we are saying is that the axis has moved beyond +90 in terms of its orientation as a vector. The other things we talk about will be extreme axis deviation, in which case the QRS complex, the vector will now be between -90 and +180, which is sometimes described as a northwest axis, So we may have an extreme axis deviation, and that range is when we have the axis between -90 and then 180. Commonly, we say that for right axis deviation, if you look at the ECG and then you are using, for example, the quadrant method, where we focus on leads 1 and say AVF. If lead 1 complex has a dominant R that is pointing upwards, and then the dart of say AVF is pointing upwards, then we usually say it's a normal axis. If they are meeting each other, then we say right meets. So commonly we consider it as a right axis deviation. And then if the R wave is pointing upwards in lead 1 and say downwards in AVF, then left leads. So we commonly say left axis deviation. But when we actually come to discuss axis in detail, we will even go ahead to try to identify the exact axis, the exact axis of the QRS, not just these mere estimations that we commonly use. So as most of us will be familiar with some causes of right axis deviation, maybe right ventricular hypertrophy, pulmonary embolism, or maybe a chronic lung disease like chronic obstructive pulmonary disease. For left axis deviation, again, left ventricular hypertrophy is a common cause, and then the other bundle branch blocks, whether particularly left bundle branch block. In inferior MIs as well, we can have left axis deviation. Okay, so as we said, we will be dealing with axis in detail. So this is just to scratch the surface. The last bit about the QRS when we are interpreting our ECG is paying attention to the R wave progression, R wave progression. And that is simply the expected increase, gradual increase in the R wave all the way from V1 to V6, V1 to V6. And we say that there is a poor R wave progression when you look at V3 and then the R wave in V3 is less than or equal to 3 millimeters. That is when we usually say that the R wave progression, that is the gradual increase in the R wave that we expect from V1 to V6, it is not as it's supposed to be. What are some of the causes? It can be from a previous MI, it can be from a right or left ventricular hypertrophy or a dilated cardiomyopathy, and it is also possible that it is just because we have actually interchanged or transposed some of the leads, for example, V1 and V3. that is also a possibility. And in some groups, it can also be a normal variant. But of course, we have to make sure that all the possible causes are excluded before we think about the likelihood of it being a normal variant. T waves will be the next thing to talk about. And T waves, we have said earlier, they represent ventricular repolarization. And T waves are upright in all these except AVR and V1. When we are looking at the T wave, we are interested in the amplitude of the T wave. And in all limb leads, the amplitude should not exceed 5 millimeters. And in all precordial leads, we expect that the amplitude of the T wave should not exceed 10 millimeters. Some of the common abnormalities that we talk about, or we should be looking out for with respect to the T wave, will include whether the T waves are peaked. So these peak T waves, they look like tall, narrow, symmetrical T waves. The other abnormality is hyperacute T waves, which may be broader compared to the peak T waves, and then more asymmetrical, sometimes symmetrical in terms of its morphology, and it's important to try and identify these hyperacute T waves because it may be like one of the earliest signs of STEMI, that is an ST elevation myocardial infarction. T wave inversions are the other thing that we need to look at. And T wave inversions usually may point to myocardial infarction or ischemia. That is, of course, with respect to the clinical context, having taken the clinical context into consideration. But if we are not talking about ischemia or infarction, the other possibilities will be, again, as a strain pattern, to say a left or right ventricular hypertrophy, that is in particular leads. So if it is right, it may be as a strain pattern in the right precordial leads, and if it is left, we may expect it in the left, say, lateral leads. So the T waves will be inverted, not representing ischemia per se, but just there because there is ventricular hypertrophy and it's there as a strain pattern. All right. When T waves are inverted, the other possibility is that it may be just an appropriate discordance. That may be the case when we are talking about bundle branch blocks and then a few other conditions. So it is not always that T wave inversions will mean that there is an ischemia. Even at times, several electrolyte imbalances in terms of hypokalemia and others may also even cause T wave inversions. So as I said earlier, the clinical context is very, very, very relevant. By and large, pathological T wave inversions are deep. When we say they are deep, they usually go beyond 3 millimeters deep. Right. So when we are looking at T wave inversions, we have to try and look at how deep the T waves are inverted. Apart from the peaked hyperacute inverted T waves, sometimes we may have flattened P waves, and then sometimes biphasic T waves, But in all of this, we always have to remember that our interpretation should be with respect to the clinical context. With respect to ST segments, the most important focus here is whether or not there is an elevation or a depression. For ST segments, depression or elevation, we also have to pay attention to their morphology, because sometimes the ST segment may appear elevated, but if you pay attention to its morphology, you realize that it may not be a pointer to an ischemic event, or say an infarction. Right. So for an acute STEMI, for example, an acute ST elevation myocardial infarction, the elevations that we sometimes see, they may be concave, they may appear as convex, or they may be obliquely straight. There may be some acute STEMI mimics. On the ECG, it may appear as though there is a STEMI, because there will be quite conspicuous ST elevations. But sometimes these are just benign early repolarizations, and these kind of ST elevations may not be, maybe mild as opposed to like ST elevations in an established STEMI. And these mild ST elevations may be associated with tall T waves as well, usually found in the precordial leads. And characteristically, they may have this fish hook pattern, around, which is like a notching around the J point. So when we see some of those features, particularly in the context where there is no chest pain per se, then we should not be too quick to diagnose a STEMI, but rather we may consider these as benign features representing just benign early repolarizations. All right. So we should also be looking out for whether the ST elevation is localized or is widespread. When I say localized, I'm referring to whether we find these ST elevations in the inferior leads, in the left lateral leads, or in the anterior leads, or septal. So because ST elevations, particularly representing myocardial infarction, may likely localize to either of these groups of leads. Whereas widespread ST elevations, especially those that look saddle-shaped, like the concave-shaped ST elevations, widespread in most of the leads, in the context of, say, a pleuritic chest pain, may more likely represent an acute pericarditis. That's the early stages of acute pericarditis. So we, in like manner, ST depressions, just like the ST elevations, may be concave shaped, convex shaped, or even obliquely straight. The ST depressions may also appear upsloping, downsloping, or sometimes even horizontal, downsloping, upsloping, or horizontal. And most often, some texts actually explain that downsloping and horizontal ST depressions may be more specific pointers to make an acute myocardial ischemia, as opposed to an upsloping ST elevation. But again, it depends on which patient is sitting right before you, and that should guide your interpretation. So for ST segment elevations, apart from myocardial infarction, some of the other causes that we should keep in mind whilst we are reading our ECG, they could be caused by Prince metal angina, that is vasospastic angina. It could also be caused by pericarditis, as we have just explained. Benign early repolarization has also been mentioned. Sometimes in left bundle branch blocks, left ventricular hypertrophy, we can have ST elevations as well. With respect to the depression, aside an acute ischemic event, say an end STEMI, for example, we should also bear in mind that these ST depressions may actually represent reciprocal changes. Very importantly, reciprocal changes to an ST elevation. And this is important to note, especially when we find these ST depressions localized to particular groups of leads, like to the inferior leads or to say the left lateral leads. Because usually, with respect to an end STEMI, these ST depressions may not necessarily localize to any of these leads. So if we are to see them in such manner, then it should prompt us that to go and look for some ST elevations in those other leads that are mirror leads to those leads that we find the ST depressions localized at. And I will stress this because sometimes these ST elevations that we should be looking for may be very subtle. They may not be as conspicuous as we'd expect them to be. And so it is important for us to look out for the possibility of such elevations so that we get our diagnosis right and manage the patient accordingly. So apart from the whole ischemic events, other possible causes of ST depression may be the Johnson effects, hypokalemia, right bundle branch blocks, left bundle branch blocks, and the ventricular hypertrophies as well. So we have just succeeded in looking at the more traditional waves, starting from the P wave, being interested in how they appear, the QRS, the T. We have looked at the usual intervals, PR interval. We have looked at the ST segment, the QT interval as well. So we can now look at some of the less common waves that we may see on the ECG. And with that, we'll start with the U wave. The U wave is a small deflection immediately following the T wave. Usually it's less than 0.5 millimeters. That's even half one small square. And these U waves, if they are present, they are usually expected to be in the same direction as the T wave. Commonly, they may be seen in V2 and V3. So if you are looking out for them, those may be the leads that we have to pay attention to. Some attribute the origin of the U waves to delayed repolarization of the Purkinje fibers. Some also say that it is because they are there because there is prolonged repolarization of some of the myocytes in particular sites of the myocardium, But for us, what is important is that when we find the U waves, we expect them that normally they will go in the same direction as the T wave. The U waves may become more visible when the heart rate actually slows down. So when the heart rate is somewhere around 60-65, we may more commonly see these U waves, which otherwise will not have been visible at faster heart rates. As I mentioned, they are supposed to be small deflections, and so a maximum amplitude of 1 to 2 millimeters is expected. And others put it that U wave should not be, or should be less than 25% of the preceding T wave. But to make it simpler, 1 to 2 millimeters in terms of amplitude. So when we are talking about the U wave, when we see U waves on the ECG, what we are looking out for will be whether the U wave is prominent, that is beyond this 1 to 2 millimeters that we have just mentioned, and or whether the U waves are inverted. We have just mentioned that U waves usually go in the same direction as the T wave, right? So if we have something opposite to that, then we can say that the U wave there is inverted. With respect to prominent U waves, one of the common causes may be severe hypokalemia in the ones and around the twos. It can also be due to bradycardia, severe bradycardia, because we have just mentioned that at when the heart rate slows down, even in a normal heart, we may see U waves which otherwise would not have been present if the heart rate was faster. So other causes of prominent U waves besides the bradycardia and severe hypokalemia, you can also have hypomagnesemia and hypocalcemia. Hypothermia can also be a cause, and sometimes left ventricular hypertrophy and some cardiomyopathies. Okay. We said that the other abnormality that we may be looking out for, or we should be looking out for, is whether the U waves are inverted. And a negative U wave, I must say, is usually notable for some heart disease. It may be a coronary artery disease, long-standing hypertension, a congenital heart disease, a cardiomyopathy. But usually when we find negative or inverted U waves, it is significant for some underlying cardiac pathology. But importantly, if we have a patient presenting with chest pain and the ECG shows inverted U waves, it is usually a very specific sign for myocardial ischemia. So it is not always that our interest should be in whether there's ST elevation or ST depression, T wave inversions. Inverted U waves, negative U waves in the context of an acute chest pain should also raise eyebrows so that we don't miss myocardial infarction. Or ischemia, pardon me. It has actually been described in some texts as like one of the earliest signs to an impending myocardial infarction. And if we are able to identify this early, then we may try to institute the necessary interventions to prevent a more sinister event. The next uncommon wave that we have to mention and probably look out for when we are reading an ECG is the delta wave. And in the earlier part of our discussion, we mentioned the delta wave as being significant for Wolff-Parkinson-White, which is one of the commonest pre-excitation syndromes. And this delta wave is a slurred upstroke. It's described as a slurred upstroke in the QRS. And as we have mentioned, it is there because of accessory pathways which lead to pre-excitation in the ventricles. And because there's pre-excitation of the ventricles, the things will happen faster. So the associated PR interval may also be, it's also usually expected to be shorter. So when we find delta waves and we find short PR intervals, then we should be thinking about a pre-excitation syndrome like Wolff-Parkinson-White. J wave, also called the Osborne wave, is the other uncommon wave that we may find and probably should look out for when we are reading our ECG. And remember, the J wave is not the same as the J points. We have described the J point as that point that marks the end of the QRS and the beginning of the ST segment, and that is found in all ECGs. J points is found in all ECGs, but the J wave or the Osborne wave is a positive upstroke that we find. It's a positive deflection that we find after the J point, and it's usually more commonly found in the precordial leads, and we may also find them in the true limb leads, So the J wave or the Osborne wave usually may be significant for hypothermia. In my country, Ghana, it may be difficult to find a J wave, I think, because hypothermia is not a very common thing here. Anyway, so the epsilon wave should also be mentioned. Personally, I haven't seen one before, but in the text, we have the epsilon wave that is a small deflection, that we find at the end of the QRS complex, and whereas the delta wave represents a pre-excitation of the ventricles, the epsilon wave represents a post-excitation of the myocytes in the right ventricle, this time around in the right ventricle. If we will find these epsilon waves, we may most likely find them from leads V1 to V2, V4, the anterior leads. And if they are there, then they are considered significant for arrhythmogenic right ventricular dysplasia. So ladies and gentlemen, all we have been trying to do is give a pattern to how we will be able to interpret an ECG. We have said that is necessary because the ECG itself may appear cumbersome, scary at a glance, but if we were to put an order, an approach to it, then we are able to make sense of what we see. We also said it's important to have the approach because if we go in an order, in a fashion order, then we are likely not to miss some vital information. And we mentioned that this approach that we are presenting is not like carved in stone. It's not like strictly what it's supposed to be. Other clinicians will have their own ways of presenting or interpreting the ECG. But the important thing is to have an order or an approach to it. So in our approach, we have mentioned that the first thing of interest is to verify the biodata. When you have done that, then you look at the rates, then you look at the rhythm. When you look at the rates and the rhythm, then you can come to your P wave, then your QRS, your T wave, then you look at your interval, the PR interval, don't forget your ST segment, don't forget your QT interval. When you looked at these traditional features, then you pay attention to the less common waves that may also be there, like the U wave, the delta wave, the J wave, the epsilon wave, and the likes. When you have done everything, then you are ready to put your interpretation into context. That is, again revisiting the clinical presentation of the patient. So the overall interpretation will be all the information you have put together from this approach that we have presented, and your history and physical examination findings. So ladies and gentlemen, thank you so much for making time with us again, watching our video, and I believe as always you are going to help us share, you are going to give us some comments and so that we can improve, as I always say. And then, as always, drop some likes for ECG Essentials. Having discussed the approach that we should go by, or we can go by, we are now much ready to delve into the topics that we mentioned earlier in this discussion. That is the common abnormalities that we intend to discuss from topic to topic. So subsequent videos that follow shortly will focus on these individual topics, starting from axis, the whole concept of axis. So till we meet again, thank you so much.